Dr. Pat Wari?
Yes.
Can I present one more patient to
Yeah,
you?
please, go ahead.
This is the guy in room 37.
Okay.
So he's a 23-year-old man with a history of psoriasis, and he presents today complaining of abdominal pain.
All right.
So the pain started in his mid-abdomen as an intermittent 4 out of 10 kind of cramping pain 5 days ago.
Okay.
It got worse last night, but then this morning the pain became constant, non-radiating, 8 out of 10, sharp pain in the right lower quadrant.
Okay.
So the pain is worse with activity, better with rest. He took ibuprofen without any relief, and the last dose was last night. So he did report associated nausea, no vomiting, a fever of 101, and that's when he took that ibuprofen last night. He's had some non-bloody diarrhea and some decreased appetite, but has been able to tolerate fluids. He denied chills, black stools, dysuria, hematuria, sick contacts, recent cold or flu symptoms, no travel, no exposure to foodborne illness, no camping trips, no hospitalizations or antibiotic use. And then he said he's never had this pain before, but he did go to urgent care this morning.
Okay.
They found him to have a fever, they gave him some Tylenol, and then they sent him here to the emergency room.
Okay, all right.
So for past medical, again, it's just psoriasis. Past surgical, he did have an ACL repaired, ACL tear repaired about 6 months ago. So family history was not contributory. Social history, he admits to drinking socially. He answered 0 to all the cage questions. He does have some marijuana use, but denies any tobacco use.
Okay.
Medications include an EpiPen PRN and ibuprofen PRN. Allergies, no medicines, but he reports a shellfish allergy. So review of systems was pertinent for a rash to his bilateral elbows. So on exam, he's febrile to 100.4. He had a blood pressure of 128/80. That was taken in the right arm. His pulse was 98, respiratory rate was 15, and he's saturating 98% on room air.
Okay.
So his general appearance, he's well-groomed, he's conversational, but he kind of appears uncomfortable. HENT was unremarkable. Neck was unremarkable. Cardiovascular, regular rate and rhythm, otherwise unremarkable.
All right.
Lungs clear. Rest of the exam was unremarkable there too. For the abdomen, he was non-distended. He had normal active bowel sounds. He was soft.
All right.
But he did have right lower quadrant tenderness. I found that he had some guarding that was voluntary, but not involuntary. He had no rebound. And then the tenderness was actually at McBurney's point. And I'm not sure if I did these right, but I think he had a Rovsing's, a psoas, and an obturator sign.
Okay.
Yeah. I didn't feel any masses. He didn't have any organomegaly. His liver and spleen weren't really palpable. I didn't notice a fluid wave or any shifting dullness. And then on percussion, he was tympanic throughout. MSK was unremarkable. His skin was warm and dry, but I did notice he's got on both of his elbows what looked like kind of an erythematous, kind of scaly white patches. Neurologic was normal and psych was normal too. So for his results, he has a white count of 21 with the otherwise normal CBC, and his CMP was normal. So for my assessment, this is a 23-year-old man with a history of psoriasis. He's coming in today for 5 days of abdominal pain that started periumbilically, but now is in the right lower quadrant.
Right.
On exam, he's febrile, and he's got right lower quadrant tenderness with voluntary guarding, McBurney's point tenderness, and Rovsing's, psoas, and obturator signs. So the top of my differential would have to be acute appendicitis. It's really kind of classic. He said it started in the mid-abdomen, and then it kind of moved to the right lower quadrant. He's got those aggravating and alleviating factors, kind of worse with activity, better with rest. And he had the associated symptoms too, the nausea, the fevers, the diarrhea, the decreased appetite. Those are all kind of typical for appendicitis.
Right.
And my exam was really spot on for this too, with the right lower quadrant tenderness, the McBurney's point tenderness, and all those signs that were positive to the Rovsing's, the psoas, and the obturator. And his labs do show some leukocytosis, which you can see with appendicitis as well. So other things that we would have to assess for too could be maybe a colitis. He's got abdominal pain. He's got fevers. He's got diarrhea. But that this distinct tenderness in the right lower quadrant, you don't really see that with colitis as much. And all those multiple positive signs for appendicitis, you shouldn't see those with colitis either. So I think that's less likely. And then another possibility could be enteritis. Again, fevers, abdominal pain, diarrhea, but he didn't really have any risks for enteritis. Like he said no to recent illness, food exposure, sick contacts, travel, all those things that would give you enteritis, he
Yeah.
said no to.
Okay.
And again, the right lower quadrant tenderness you really wouldn't see with just enteritis. It would be kind of more of generalized tenderness.
Right.
So my plan is as follows. I'd like to order a CT scan of the abdomen and pelvis.
Okay.
And then
Good.
maybe a stool culture.
Okay.
Okay. And then therapeutic plan. He's in a lot of pain. I think we should do some IV morphine for him.
Yeah.
And then if that CT comes back and it shows appendicitis, I would like to consult general surgery for an appendectomy.
Sure.
And then at that
Good.
time, I think we should start some IV antibiotics.
Okay.
Education plan, I don't know, I really don't know. But I think if he's going to have surgery, maybe we could educate him on kind of appropriate post-surgical
Yeah.
care.
That's
and then
good.
Admission would be my disposition plan or right to the operating room.
Perfect.
Okay.
All right. Great job.
Thank you so much.